to the afternoon session. Hope everyone had a good lunch. I love a hospital that sells wine at lunch or has wine at lunch. I think that's excellent. This afternoon we're going to talk a bit more about ovarian cancer staging recurrence. So we're moving away a little bit from just diagnostics, ADNEX models and stuff like that, and we're moving more into the area of staging. First speaker is Daniela Fischerova. I'm really pleased to see Daniela here. Daniela's been a big part of the IOTA project, and I'm sure all of you know is a card-carrying surgical gynecological oncologist, but also is exceptionally skilled in ultrasound. And she's going to talk about using ultrasound to stage ovarian malignancy. So, Daniela, thank you very much.
Thank you, Tom, for the introduction. Dear colleagues, dear friends, it's always a pleasure to be here, and I will talk about the ultrasound and the role of ultrasound in ovarian cancer staging. You know that currently the gold standard in staging of ovarian cancer is a CT, but ultrasound is already recognized to be the first-line technique to discriminate between benign and malignant masses, but also in the experienced hands to detect the tumor spread in the pelvis and abdomen. And certainly it is the first-line technique to navigate through cut biopsy for obtaining adequate histological diagnosis. Do we have any evidence on ultrasound in ovarian cancer staging? There is a study which was published by Antonia Testa on 147 patients with advanced ovarian cancer and showed very good correlation between ultrasound and intraoperative findings. The second study was published recently, came from Prague, from my department, on 349 patients, mainly with advanced ovarian cancer, and I will walk you through some results. This is a very busy, complex table containing data from our study on all sites evaluated. Since the peritoneal involvement is a key element in the management of ovarian cancer patients, I will show you some results and their practical impact. First, we will focus on the pelvis and peritoneal spread in the pelvis. And I will show you a video showing the visceral carcinomatosis on the bladder, the visceral carcinomatosis on the posterior wall of the uterus, parietal carcinomatosis in pouch of Douglas, visceral carcinomatosis on the rectosigmoid, and the mesenterial carcinomatosis, which is located between the posterior wall of the sigmoid colon and the sacral bone. So first we move at the anterior compartment. There is a large amount of ascites, the uterus, in anteversion flexion, and this thick hypoechogenic diffuse carcinomatosis not infiltrating the bladder and is highly perfused. We move to the posterior compartment, and there is a large implant, hypoechogenic implant of carcinomatosis attached to the posterior wall of the uterus, infiltrating the sacrouterine ligaments. And towards the pouch of Douglas, there is the rectum, and thin, hypoechoic diffuse carcinomatosis, not infiltrating the wall of the rectum. There is still the fat tissue between. But if we follow up the rectum in the oral direction to the sigmoid colon, you will notice this thick carcinomatosis on the sigmoid colon. And in that point, we already here lost the muscle layer, the hypoechoic muscle layer of the colon disappeared because of tumor infiltration. The carcinomatosis infiltrates the muscle layer of the sigmoid colon, and we know that the sigmoid resection will be needed. And lastly, we will look between the posterior wall of the sigmoid colon and the sacral bone, which is this echogenic line. And you can nicely visualize these hypoechoic nodules contrasting with the echogenic fat tissue of the mesentery. So in the pelvis, due to transvaginal probe, you have a beautiful resolution. Therefore, not surprisingly, we have shown in our study that ultrasound had an excellent results for detection any peritoneal carcinomatosis in the pelvis, including the assessment of the depth of rectosigmoid infiltration, which is very important for clinical practice to plan rectosigmoid resection. But what about the upper abdomen? So in the upper abdomen, first we visualize the parietal carcinomatosis on the diaphragm, then the visceral carcinomatosis on the surface of liver, and I will show you in this video this nodule, carcinomatous nodule, obliterating the hepatic hilum. First, we move to the upper quadrant, to the right hypochondrium. Maybe we can reduce the light slightly. And there is a hypoechogenic nodular diffuse carcinomatosis on the diaphragm, ascites around the liver, and the carcinomatosis is again highly perfused. Can we reduce the light? Is it possible? And we move to the liver. The surface of the liver is smooth, or seems to be smooth, but thank you. Between the right kidney and the liver in the Morrison space, you find these irregular subcapsular lesions, which are subcapsular metastatic lesions deeply infiltrating liver parenchyma. And lastly, we move to the hepatic hilum, and there is a nodule obliterating the celiac trunk, mainly obliterating the splenic artery, which is arising from the celiac trunk. But if we look on our data, ultrasound reached low sensitivity, specifically in the diaphragm. There is the sensitivity in a study about 30%, but the specificity was very high. From clinical point of view, the specificity is more important because you can arrange a multidisciplinary team for resection of liver. At the same time, the undetected findings on ultrasound on the diaphragm, on the liver, or on the spleen can be usually routinely cytoreduced by experienced oncosurgeon. So in this case, for us, it's more important the excellent specificity. What about the middle abdomen? I will show you the omental infiltration because this is the part of the carcinomatosis. The omentum is the largest fold of the peritoneum. And then we move to the right hypogastrium to show the visceral carcinomatosis on the ileum, mesenterial carcinomatosis around ileal loops, and lastly we will go to the left paracolic gutter to demonstrate the parietal carcinomatosis. So in the abdomen we have omental carcinomatosis, visceral, mesenterial, and parietal. We start first to examine the omentum, the greater omentum in sagittal view in the midline. To get oriented, you must differentiate it first the antrum of the stomach, and between the greater curvature of the stomach and the transverse colon, you will find the supracolic omentum with hypoechoic nodule. You pass the transverse colon and there is a omental cake embedded the transverse colon. And we go caudally, we go towards the pelvis. And to differentiate it, the omental cake, just note that the omental cake is a rigid structure in contrast to the loops which are mobile around the omentum. There are multiple nodules, hypoechoic nodules. The loops are really mobile in contrast to this rigid structure. We go back to the liver. We pass the transverse colon. The wall of the colon is probably infiltrated. And between the colon and the antrum of the stomach, we identify this nodule in supracolic omentum. So this is the omental infiltration assessment. And now we will move, after we finish the examination of the supra and infracolic omentum, now to the right hypogastrium. This is the ileal loop entering the cecum. This is the cecum, this is ileum, there is the vulva. And there are multiple hypoechoic mesenterial nodules contrasting again with the fat tissue of the mesentery. But there is not only the mesenterial nodule, but one nodule, only one, here, on the surface of the ileum. So we have visceral carcinomatosis here, but it is only one nodule, not compromising the peristalsis of the ileum. However, it's important to know about it if you would like to initiate bevacizumab, for instance, because of the risk of perforation. We see the multiple mesenterial nodules here, and I will magnify the image, which I do, and you see that this nodule on the ileum is really infiltrating the muscle layer of the ileum. It's very important findings. And we move lastly to the left paracolic gutter, and there is a carcinomatosis which is growing from the pelvis. From the pelvis, I go to the pelvis, it is towards the pelvis and up. From the pelvis to the left paracolic gutter, just near to the descending colon. The frequent questions I often get, is whether we can examine on ultrasound bowel without preparation, without patient's preparation, without fasting. And as you can notice, you can really examine the bowel. It's here and it's nicely visible. This is the transverse view, so here is the nodule, this is the carcinomatosis, descending colon, and you can identify that the nodule is growing in the wall of the descending colon. So you can use ultrasound to assess the bowel surface and bowel mesentery. But our data on the assessment of omental infiltration, ultrasound showed good sensitivity, but we don't need it, so it's not really needed for clinical practice because we know that the total omentectomy is a standard procedure during cytoreduction. What is more important for clinical practice and one of the major criteria for deciding on upfront surgery or neoadjuvant chemotherapy is whether ultrasound can detect bowel and mesenterial infiltration, and the sensitivity was really not satisfactory, which may lead to suboptimal surgical results. So this was really crucial findings from our study, that the sensitivity to detect bowel and mesentery infiltration of ultrasound is low, although again the specificity is excellent. We move to the lymph node infiltration detection using ultrasound, and you can notice a really difference of sensitivity in ultrasound detection of retroperitoneal lymph node and inguinal lymph node. And it is based on the fact that the inguinal lymph nodes are located peripherally. They are very close to the probe, so you can use high-resolution linear array probe, and you can detect really a detailed lymph node architecture. This is infiltrated, completely infiltrated lymph node with irregular margin. And this is a normal lymph node with a typical architecture with the medulla, with the cortex. The same advantage you have if you use the transvaginal probe to detect iliac lymph nodes, the internal and external iliac lymph nodes up to the interiliac bifurcation, if you use the transvaginal probe. But with the transabdominal probe, I will show you the limitations. And specifically in the para-aortic regio, the lymph nodes are located deeply in abdomen, and you can use only convex linear array probe. We start in the left side, in the groins, and first we will follow up the femoral vessel, vein, and artery in transverse plane towards the inguinal canal. And you can nicely recognize the infiltrated lymph node with some necrosis, with irregular margin, and completely normal lymph node with normal longitudinal hilal vessels entering the hilum of the lymph node with the medulla and with the cortex. Now we are examining the iliac lymph nodes using transvaginal probe, and there are two densely packed lymph nodes together. And you have a very nice view of the architecture, and there is a perfusion in the periphery. And such a view you will never achieve using the transabdominal probe. And I have a video at the same patient, and you see there is a shadow caused by the sigmoid colon. So you can maybe have some suspicion there are infiltrated lymph nodes, but you cannot see them so nicely, and you cannot omit it, this shadow. So you are handicapped. Try always use the transvaginal probe if it's possible. And now we are examining the para-aortic lymph nodes. We have the inferior vena cava, aorta. We are in the sagittal view, and there are multiple confluenting lymph nodes. However, now I turn the probe 90 degrees counterclockwise. So I have here the aorta, inferior vena cava, and in this location, interaortocaval, you see these infiltrated lymph nodes, which are just confluenting to each other. So all of lymph nodes are infiltrated, and they are located interaortocaval, between aorta and inferior vena cava. Ultrasound reached low sensitivity in the detection of retroperitoneum, but again, from clinical point of view, the systematic lymphadenectomy is a standard procedure in order to achieve the optimal cytoreduction. But what was really important findings that ultrasound showed very good specificity in detection of infiltrated inguinal lymph nodes. In other words, if we assess the lymph nodes as positive as infiltrated on ultrasound, they are almost always infiltrated on pathology. You might be surprised by such a high sensitivity of ultrasound in detection of inguinal lymph nodes, but it is related to the fact that we removed only lymph nodes which are positive, which are suspicious of infiltration. So ultrasound can be used to plan the inguinofemoral dissection. But the next logical step would be to compare ultrasound with modern imaging techniques. Such study ran in 2000, it was a multicentric prospective study, included 118 malignant tumors, and the authors summarized that ultrasound can be a very good alternative to CT and MRI in hepatic and lymph nodes assessment. But I would like to show very shortly data from a pilot study which ran last year at my department, and my PhD student Patricia from Portugal helped very much with a study. And we compared ultrasound with whole body diffusion weighted imaging and contrast enhanced CT in the assessment of 27 anatomical sites. And we included up to 972 patients. However, I will show you the first data after we included the first 21 patients. So if we look on the data just roughly, because it's really small cohort, it was analyzed in summer. In pelvis, all three techniques were very accurate to assess peritoneal spread. On diaphragm, ultrasound was less sensitive, but the sensitivity was higher in the detection of visceral carcinomatosis on the liver or on the spleen. It's maybe related to the fact that we can see how the liver or spleen move by breathing against the diaphragm. In the omentum, all three modalities were very sensitive, but they were less sensitive in the detection of retroperitoneal lymph nodes. The sensitivity was identical, 60%. But for deciding on optimal cytoreduction, the most critical point is to assess the bowel infiltration, the bowel visceral carcinomatosis and mesenterial carcinomatosis. And not only ultrasound, but CT and whole body MRI have limitations in detection of this involvement. Therefore, we may add diagnostic laparoscopy in cases where we are uncertain about the infiltration of the bowel and mesentery, just for the reason that the discrete infiltration is oftentimes undetected. I moved to the conclusion. First, I would like to tell you that all videos you have seen are narrated and included online to this manuscript. So if you would like to see them again, they are online available. And I would like to repeat the results from the study. First, ultrasound shows an excellent sensitivity in the detection of peritoneal spread in the pelvis, omentum, and inguinal lymph nodes. Therefore, can be used to plan rectosigmoid resection and inguinal lymph node dissection. Unfortunately, in all other sites evaluated, ultrasound was less sensitive. Specifically, the undetected bowel and mesenteric infiltration may lead to suboptimal surgical results, which may happen in 1/3 of patients. Not only ultrasound, but also contrast-enhanced CT and whole-body MRI with diffusion-weighted imaging have limitations in detection of bowel in mesentery in our study. I believe that Vincent will have much better results, but this study is unique because there is ultrasound compared with other imaging at the same cohort of patients. And on the positive note, ultrasound, based on the high specificity of ultrasound, we can use it safely to triage the patients either to upfront surgery or to neoadjuvant chemotherapy. This is the management or algorithm we use at my department. So on ultrasound, the patients who are assessed on ultrasound as inoperable, they undergo ultrasound-guided true-cut biopsy and adequate treatment. If they are assessed operable, they go to primary cytoreduction. Based on the results available from our study, we changed slightly the algorithm, and we have added diagnostic laparoscopy just for cases when we are uncertain about the presence of mesenteric and bowel infiltration. And I would like to acknowledge my team. Here is not only the imaging expert from radiological field, but they are also, of course, some skilled oncosurgeon, which is the whole group. But at the same time, they are ultrasound experts equipped with high-end ultrasound capable to do ovarian cancer staging. And you will see all of them during international workshop on ultrasound in gynae-oncology in Prague this year. If you attend the workshop, you are more than welcome. Thank you.
Daniela, thanks very much. Any questions?
Juan, yes.
One question,
yeah.
Someone. Sorry, there's a hand waving in the darkness.
For your excellent presentation. I would like just to make a comment. We have forming a similar study you're doing right. With the abdomen. We have so far like 60, 70 patients. And the positive thing, we agree with you that we can see all that we want to see, all right?
Specificity.
But the positive thing is that in our study, so far, CT scan is not better than ultrasound. The sensitivity and specificity for each anatomical assessment we have done, diaphragmatic, pelvic, lymph nodes, upper abdomen, mid-abdomen, it's quite similar. There are no statistical differences in terms of sensitivity or specificity when compared. So it means that ultrasound can do the same role that we are asking to CT scan. Okay, we do not need CT scan to see where the disease is. The second comment is regarding how triage. By using ultrasound, you have a pretty good sensitivity to identify those areas in which the patients can be considered. Certainly, most of the hands of the gynecological surgeons as known resectable disease. No, you are not going to achieve complete resection at all. For example, intrahepatic parenchymal disease, and for example, lymph nodes above the renal vessels. So in this case, before said that the probability to achieve complete is going to be quite low. On the other hand, ultrasound is very poor to identify miliary carcinomatosis, which can be easily identified by laparoscopy. Our proposal, if you don't identify this with the parenchyma, the spleen, liver, or lymph nodes above the renal vessels, do laparoscopy to identify if there is a miliary disease, because this is another criteria for non-complete cytoreduction. Miliary carcinomatosis, then you can go ahead and try to upfront surgery, achieving cytoreduction. That's my comment. Thank you.
Thank you very much. You summarized, I think, very nicely the point. And
so, you have no disagreement with what he was saying. It's the same, isn't it?
Yeah. It is exactly the same. We don't do a diagnostic laparoscopy by all of them, but we do it if we are uncertain, like we have large amount of ascites, diaphragmatic spread, and something which Antonia Testa called like cauliflower sign, for instance. We have suspicion there is maybe retraction of small intestine, but we cannot see really mesenteric involvement. We don't see really some implants on the intestine, so we start first with diagnostic laparoscopy because we expect there must be miliary spread, because if it's everywhere visible on diaphragm, maybe on the liver also, but we can do peritonectomy on the liver or resection, then we expect maybe there is a really high chance there will be a miliary spread on, and we start with diagnostic laparoscopy. Exactly, yeah.
Okay, Daniela, thanks very much. I suggest we move on to Vincent because he's going to be discussing whole body MRI, so maybe we can have some discussion after that. Daniela, thank you. And now I'd like to introduce Vincent Vandecaveye, who's come all the way from KU Leuven. It's been a big job for him. And I know Vincent's obviously been working with the team here, both with Dirk and the oncology team for some years now. And he's going to discuss whole body MRI to stage ovarian cancer and also touch on PET-CT for recurrent disease. So interesting to see what you have to say and whether you might, during your talk, also kind of reflect on what Daniela's been saying, just to kind of put it in context would be great. Okay. Thank you very much.
Thank you. Maybe if also the light can be dimmed, for radiologists always not good to be in the light, actually. We like more shaded areas. So what we talk mainly about whole body diffusion. So it's nice, I always get this chance also to talk about PET-CT. In Belgium, nuclear medicine radiology are separated in part. We do the CT part. So I will compare the evolution of the two techniques and mainly emphasize on whole body MRI. But I think what we should not forget when you ask an imaging technique to assess operability, that we don't need to find every tiny nodule that is there. We have to assess the risk of surgical critical lesions. And also for the radiologist, let's not forget it. The first thing we have to do is that we are actually dealing with an ovarian cancer. I think everybody knows there are enough malignant ovarian lesions that originate from colon cancer, gastric cancer, and so on. So this is the first step in the staging. Second is the question for resectable peritoneal disease. I'll come to that later. But also, actually, there are quite a deal of patients with supradiaphragmatic disease, and at least for our center, that is a determinator in a number of cases not to perform primary debulking surgery. When we have suprarenal lymphadenopathy along the lymphatic chain parasternally, or macroscopic pleural metastasis and the supraclavicular lymphadenopathy, there will be no primary debulking, and in some cases, an axillary lymphadenopathy could be resectable. Second, can we achieve complete macroscopic removal? Of course, MRI, you should only use it when you are aiming for complete tumor resection. If the standard would still be less than 1 centimeter optimal reduction, there's no way any imaging technique can predict that. So you have a binary question, yes or no complete reduction. And then the detection of FIGO stage 4B. Well, for Belgium, for instance, that means that you can add bevacizumab to neoadjuvant treatment. So this is also important to keep in mind. So of course, CT is the workhorse. It is a bit difficult. It is far from optimal, but it can give you quite a good overview in advanced disease. But we all know that a CT scan alone cannot predict optimal debulking surgery and should, as such, preferably not be used. And PET has put us on a way to that, to improve that. And its potential strength is nodule staging, as we see, compared to conventional MRI. So these were studies where diffusion MRI was not yet added. Then PET-CT has a higher sensitivity combined with high specificity to detect lymph node metastasis. And this is quite good to detect the stage 4 patients. But its potential weakness is peritoneal staging, considering the limitations in spatial resolution. So small peritoneal implants cannot be detected, the one that are diffuse infiltratis, and if overall you can see that there is quite a high false negative rate. So it is difficult with PET-CT to predict peritoneal operability. Let's look at this case. So PET-CT actually indicates the patient is inoperable. There is a lymphadenopathy along the right parasternal area. You can see the omental cake, but look at the CT. And from laparoscopy, we know there is a diffuse tumoral infiltration of the small bowel and the mesentery. And look what you see on the PET, nearly no disease on the peritoneum. So you can see the strength and the weakness of PET-CT. And this is where we bring in the diffusion-weighted MRI. So usually, what is it in basically? What the diffusion does, it measures the random movement of the water molecules. That's the Brownian movement. All water molecules are moving around in the air, a glass of water or in your body. So you have the blood vessels, and this is a pancreatic inflammation. It is a pseudotumor. They have biopsied it because they were not sure if it was a cancer. And as you can see, what is typical for benign tissue inflammation of necrosis is that the interstitial space is large. So you can see many happy green-faced water molecules. They can swim around as much as they want. This is what we call facilitation of diffusion. And basically, a tumor is not visible on a benign tissue and inflammation necrosis is not visible on the diffusion MRI. When we have the pancreatic cancer here, it is packed with cells, a lot of vessels, and then you can see that this interstitial space is really diminished. This is what we call restriction of diffusion. The water molecules get some hypertension, really red faces. They are stuck in there, so the signal stays there, and the tumor starts to give the signal as very bright. Now, there are two important things. Belgium, with the land of the surrealism, this famous artwork, ceci n'est pas un pipe, diffusion, ceci n'est pas un PET. It shows the same, like the PET, but in a different way. PET will show metabolical activity, diffusion, the microstructure of the tumor, but that means that when you give chemotherapy to the tumor and it gets metabolically depleted, your diffusion will still be able to detect the background of the tumor through its microstructure. And one of the big advantages of the diffusion MRI is the spatial resolution that we gain down to 3 to 4 millimeters. So when we ask me, will I see small projections of 1 or 2 millimeters? Probably not. But this is the lowest that we can go, while the PET can go to 6 to 10 millimeters. So why would whole body diffusion or abdominal diffusion then be used in peritoneal carcinomatosis, and what is its advantage? Well, when we look on a per patient basis, there is no advantage. Both techniques are very well in detecting disease, and for instance, if you want to see if there's recurrent ovarian cancer, both techniques are very well for detecting it. But when we start to make subdivisions that may be surgically important, you can see that diffusion gains the advantage in sensitivity for detecting the maximum number of deposits. And that is just what is needed to get an assessment of operability. Like in this case, there's a big mass behind the stomach, but on diffusion, you can see that you also need to resect peritoneal metastases around the liver. So, where does whole body diffusion make a difference? There is a number of studies. We are now finishing a larger study and over 100 patients, and actually that's an intermediate analysis of a study in 360 patients. It takes some time to finalize it off. But what is always coming back, and I don't talk in absolute numbers, is that whole body diffusion beats CT and FDG PET-CT for peritoneal staging. And then I'm talking in terms of subdivisions. Subdivisions of total tumor spread, but especially, and I will show that later, for surgically critical tumor spread, what your surgeons ask to you. And that's a very important distinction. And it has equal accuracy as FDG PET for detecting the chest metastasis. For ovarian cancer, that is mostly lymphadenopathy and pleural metastasis, and rarely liver metastasis. So this is an important point. The last study in 2016 said there was a better observer agreement with diffusion MRI compared to CT, although we always say diffusion MRI is more difficult, but that shows that there's a better depiction of tumor, but it was not superior for the detection of serosal disease. We found other things. We found that diffusion MRI was vastly superior over CT and FDG PET-CT to detect serosal disease, most pronounced on the small bowel, but also on the colon. And you can see this in this example. This is a patient with diffuse infiltrative carcinomatosis. PET has difficulties to see it. The CT will not help you because of the low contrast resolution. But look, probably I miss a lot of papillary metastases here in the middle in the meso. They are visible here on the left, multiple metastases, and here on the colon. But is this really now the information you need? You know you cannot operate this patient anymore. This is the portal vein, and the tumor has invaded circularly, completely around it. So this probably already makes the patient inoperable. So that means that there are a number of prerequisites to do diffusion MRI. First of all, to optimally see the serosal disease, we need a negative contrast in the small bowel, and we need an antispasmodic. This is a normal volunteer. No disease, but also no medication and no bowel distension. And you can see that there is physiological signal over the small bowel due to the contractions. So we gave an antispasmodic, and we gave a water-based solution, but you have this strange feature called T2 shine through on diffusion MRI. That means when you have water and the signal is that high on the diffusion that you have remnant signal on the high B value. Well, this is water, and this is peritoneal carcinomatosis, so it's difficult to make that distinction. So we came up with pineapple juice, and in case patients cannot have pineapple juice, for instance in diabetic, you can give diluted barium. Barium that you give with the X-ray, like for instance a stomach examination, 7% diluted in 1 liter of water. And what is the special thing about pineapple juice? It contains manganese. That's a metal. An MRI is a magnet. Metal becomes black in a magnet and in the MRI. So you can see the stomach has become completely black, which facilitates also the visualization of this metastatic deposit behind the portal vein, but then also all these small serosal implants on the small bowel as the signal gets suppressed on the small bowel. So that doesn't say that we cannot see disease, but it maximizes the diagnostic capacity of the diffusion MRI. And the second one, that we need to be as good as FDG PET for distant staging. Meta-analyses have shown that is the case also for nodal staging, and these are examples. This is one of the rare cases where we had a lung metastasis and also 2 mediastinal lymphadenopathies, and you can see that the diffusion makes the mirror image of the FDG PET. So if you can do that, then we can really look at the problems that we are facing. There is a large variability in the definition of optimal debulking, but normally there should be no residual tumor. But more on, there are probably as many operability criteria as there are gynecological surgeons. So we have to be very flexible in that as a radiology and really talk to our surgeons. And there is one lucky thing, we have this high inter-observer variability agreement, so that means that we can really adapt the technique to what you wish. So when we go to the standardized predictive scores, there are a number of scores that you can do. This was done in a study by Espada and colleagues from Madrid. Well, they took a number of determinators of inoperability. And actually, when they combine the optimal set of predictors, they say that rarely they have a patient that they said patient is inoperable and he turned out to be operable, but still 25% of patients that they say patient is operable will still be inoperable at primary debulking. And one of the problems that you have with standardized predictive scores, for instance, involvement of the diaphragm, for my hospital, that is not a contraindication for surgery, so we don't use it. And that's why I think standardized scores are probably less reliable to be implemented. So that means center-specific scoring, and actually when your radiologist starts to do this, he has to come to talk to you and ask what are the institutional operability criteria, and the MRI will be looked for in that way. So Professor Verhoeven came a number of years to me, and I wasn't even thinking of doing this work, and he asked if we could scan a patient. And as you can see, I was extremely happy. It was a new application. And then I saw how difficult it was, and I got a really serious face. And this is what he gave me. I want a protocol like this. These are the criteria for Leuven. So, of course, they want a biopsy here. This is something we cannot do with the MRI. And then a number of criteria that determine the inoperability. A lot of the classic ones, like bowel mesentery invasion, serosal invasion, distant metastasis, and so on. So that is how we do it. This is a patient who came with the suspicion of diverticulitis to the emergency department, but it was an ovarian cancer with metastasis. Okay, this is still operable. And when we look at the CT, there is limited disease in the upper abdomen. Well, this is the diffusion MRI with its contrast-enhanced counterpart. Diffuse invasion of the mesosigmoid and sigmoid, but look here, we are at the level of the duodenum and the gastric outlet. There is diffuse serosal spread and a lymphadenopathy, probably already a determinator of inoperability. Lymphadenopathy behind the portal vein, here is the portal vein, so they are right behind it. And then also high in the liver hilum, along the left intrahepatic portal vein, there is also diffuse metastasis. So we don't say in our report, this patient is inoperable, that decision is up to you. But we come to the oncologic board with, we have a number of surgically critical disease sites that are affected with metastasis. And that's how they come to a conclusion. So the high sensitivities and specificities that we report, like when we say irresectable distant metastasis, that are the lesions. But they want to know if there's diffuse serosal carcinomatosis. So we make the distinction based on the operability criteria. And for Leuven, it means if you have more than 1 meter, 20 centimeter small bowel involved, it becomes inoperable. So with the MRI, we have to make that distinction, focal disease or diffuse confluent infiltrative small bowel disease. And that's a whole different thing than do we see every tiny nodule in the peritoneum, because for every imaging technique, that is impossible. But again, first, reliably assessing the primary tumor. So the intermediate assessment in 161 patients, this has been presented already as abstracts, and we are finalizing the manuscript. This is a patient, ovarian mass, a hint of a liver metastasis, that's already quite strange, and a mediastinal lymphadenopathy. Well, look, there's a liver metastasis. It is diffusion restrictive, bright. The lymph node is not visible, and this was actually sarcoidosis. So we made it, despite the size, we said this was an inflammatory lymph node, so no lymph nodes above the diaphragm. This, I say now, ovarian metastasis, it has some features, and actually that is also a kind of a central vessel sign. Often we see on the contrast MRI the central vessel penetrating the mass. But look here at the small bowel, there is a small focal tumoral mass, and the connection was quite quickly made with the liver metastasis that this was an intestinal neuroendocrine tumor, and that was confirmed during surgery. So how well do we do? This is predicting incomplete resection using these five surgically critical disease sites compared to CT, and then you can see that there is extremely high positive and negative predictive value. So what do we accept as a radiologist? We will accept more that we tell you it is operable and that the patient is non-operable. These are the patients that probably you will do a laparoscopy even after the MRI. But what we cannot accept is that we say that the patient is inoperable while the patient was operable. That is something we really have to avoid, and this is how we put our criteria. So the three false negatives that we had here were three patients with only miliary disease of 1 to 2 millimeters. So that we were impossible to see, indeed. When we compared the whole body diffusion with CT combined with laparoscopy for operability assessment, we found that the technique was non-inferior, so it showed actually the same operability assessment. But of course, we cannot perform a biopsy, and the patient is also not always accessible for percutaneous biopsy. So this does not replace laparoscopy, and we have to think in future also what diagnostic strategies would be optimal to combine whole body diffusion and laparoscopy, because both have their strengths and their limitations, and they are highly complementary. So when we look at some cases, this is a patient on CT, stage 3C, with diffuse metastasis. You see the micronodular lesions on the mesentery. Also here, micronodular lesions on the mesentery. And this is the whole body diffusion. On the right side, I think it is quite clear. And you only need one slice to see that this patient is inoperable. This is diffuse mesenteric and serosal disease. But here, nothing. So the question is low resolution or no lesions at all? Well, there is a hint. There's no contrast enhancement in this solid mass, which is quite typical for an ovarian fibroma, and this was a MACE syndrome. So we said no peritoneal disease, benign tumor, and explorative laparotomy was immediately performed and confirmed the findings of the MRI. This is an example of a stage 3B, somewhat limited mesenteric and serosal disease, but not at the volume that would inhibit primary surgery, some lesions around the liver. And here you can nicely see you have the small intestine and these small, very small bright spots on it. These are small metastases on the bowel, and they were confirmed on the surgical images. Also here, it is not always high volume disease, but I show this case. CT shows omental metastasis. The root of the mesentery is okay, but that is not the case on the MRI. These are the major vessels of the mesenteric arteries, and you can see that the tumor glides around these vessels. So this patient has a central tumoral encasement. If you want to resect that, you have to resect all the small intestine. So likely this is really critical for surgery, and that is how we're going to report it. And of course, distant metastases, they are quite an important finding, and in more patients than we expected before. So to finalize, short word on recurrent ovarian cancer, where we start to get the same, maybe the same diagnostic setup, but in a more limited amount of patients, because you already have a good clinical discriminator before that. You have the AGO score, so complete resection at primary surgery, good performance status, and absence of fasciitis, gives a complete resection rate chance of 76%. So it's up to us to scan this other 24% of patients or find these other patients. And that is very important because one of the reasons for incomplete resection is disease localization. And therefore, when we have a patient with resistance to chemo, so an early recurrence or a lot of ascites, they will not ask an MRI. But in other cases, when AGO positive score, a good AGO score, they will ask an MRI for further assessment. So also here, PET-CT has done advantage. It's really good technique, better than CT, to detect the recurrences. But it suffers a bit from the same problems as it is for peritoneal staging. So here, a lymphadenopathy that was detected, and also here, and I show lymphadenopathy with a purpose. It has problems with peritoneal staging. I have searched some literature throughout the years, and it is really variable. But one of the problems with imaging studies, and that's something we really have to do better, is that always there are other criteria for how should we look at it and how should we look at the peritoneum. But this is an ongoing study looking to apply HIPEC in recurrent ovarian cancer, and at the intermediate analysis, PET-CT is actually less reliable than CT to predict peritoneal operability. And this is a patient who has diffuse carcinomatosis, but the PET actually said there were 2 lesions in this case. So this is a study we published in the British Journal of Radiology. Basically, I will not repeat, it is the same like with primary ovarian cancer. Diffuse carcinomatosis of the intestinal structures, mesenteric root, and distant metastasis. But what it does, and probably that's more important for recurrent ovarian cancer, because at least at our center, they are less likely to do laparoscopy in this setting, that there's a correction of the CT when CT says the patient is operable, so an underestimation of disease, but that whole body diffusion is also very reliable when the CT is overestimating disease and says the patient is not operable. The MRI is also able to correct that. So this is the difference that we have in lesion location compared with the CT. This was correlated as this was part of the study. And I can tell you, we saw about 75% of lesions. So there were for sure a high number of lesions that we missed, but we saw the lesions on the stomach and multiple intestinal structures. So the patient was already inoperable. And this is the patient that I showed previously with PET-CT. Well, compare the PET with the whole body diffusion. There is diffuse carcinomatosis, but I'm honest, this is a recurrence of a low-grade ovarian cancer. This is non-FDG avid disease, but that's an additional advantage that we have. So to conclude, I could show the evolution again from CT, PET-CT, and whole body diffusion MRI. I think the most important to say is that we are not competitors. You have to find the technique that is most convenient within your setting. I should have put ultrasound also here, I understand. But for instance, one of our weaknesses is we can assess very well the total disease spread. We have more difficulties in predicting the invasion of the rectosigmoid. So you see, you always have complementary value. And at the end, what we aim for is optimal patient management, and that's what we try to help with this. I thank you for your attention.
Thanks very much, Vincent. We're slightly short of time, so one question. I mean, I guess it's, you say they're complementary, but if I was recruiting to set up a new unit in London and I wanted to decide what, I was going to do, and it was, just out of interest, because, yes, it's okay if you say, well, just use the technique and effect you're most skilled at in your particular unit, but if I wanted to just say, right, I can have anybody, who do I recruit? Daniela, you, who? Which one do I go for? Who do I get to come and do this?
If you have a good contract, we can talk. No problem.
We'll have a word later. But I suspect it's NHS. Disappointing. I'm afraid. I'm sorry.
I think as of 2018, I'm planning to set up workshops for training for this. So I think one important thing is technical optimization, and I know a number of people are doing this technique. In 2017, I will try to gather everybody. It is not that difficult that you cannot just start it up. You just have to know when you start up with the whole body diffusion, give your radiologist like 40 cases of chances of making mistakes and give him excellent correlation, and it will start running very well after that.
So in high volume centres, obviously, because
High volume
as it should be
centres.
anyway. Yeah.
That's the way we collaborate in Belgium. The lower volume centers are either doing their OR scans and they come as a consultant to our hospital to keep seeing enough patients, or I do second opinion of their scans if they only have their volume. Preferably, it goes just with the high volume of surgery. Your radiologist has to go in that high volume. If you don't see enough patients, it's no use to do it.
Because I always find, Daniela, with ultrasound, because I probably don't do enough, but when I see something, it's like, yeah, okay, but it's having the confidence to say there's nothing there is more difficult. Do you know what I mean? To say that there's no disease is harder to feel totally confident to tell someone it's fine, because when you see something there, you can see it, if you know what I mean. Does that make sense?
Yeah, well, there are nights that I'm not sleeping about that, indeed, when you say it's negative. So that's also what we see in the collaboration with our gynecological surgeons. When we say inoperable and there is some access for biopsy, they are very likely not to do laparoscopy. When I say operable disease or negative, they are in a high number of cases still doing this laparoscopy, and I think that's a good way to do now until we are more sure when is it safe to say it's really negative.
Okay. Daniela?
Yes, thank you. I don't have any comment. I really think that, but I have a comment of my radiological specialist on MRI, which I would like to hand it.
Just thank you for invitation. I will visit your center. I will visit the workshop because I think we are not as experienced as you, so they are the results. And I can say it's very difficult for us because it takes nearly 1 hour. And it is difficult for our patients because they are covered by coils and in the small space. So we have these problems, these difficulties. So we will see. I hope that we will improve our technique and our evaluation.
Thank you very much. Shall I take the microphone? Vincent, thanks very much indeed. Apparently I'm Antonia Testa. Okay, that's unlucky, Antonia. Okay, so managing system predicament. Fantastic. Thanks so much, Vincent. We're running short of time, so I'm going to say very little and then hand over to Antonia. I think that's probably the sensible thing to do. I only have one cross-sectional image. I thought, Vincent, you could comment on this. I found this at Leuven. It's very unfortunate. You can see here, breaching patient confidentiality. Unfortunately, the radiologists were unable to find anything inside his head. But there you go. I just thought it was worth pointing out very quickly before we hand over to Antonia, who principally works in mainly a cancer centre. So if Antonia stands up to speak, I am sure she's going to present loads of complicated masses that she's biopsied and done all sorts of clever things with. But it's always worth remembering that actually nasty things in the young population that comes in early pregnancy, they're generally relatively rare. And most of the cysts that you see are benign. Most of them will just go away and will resolve. And you're left with the kind of cyst that you would expect in a bunch of young women, which is endometriomas, dermoids, and so on. And then you have a few borderlines, but actual invasive cancer or some of the more rare tumours, they're always going to be relatively unusual. And I don't have any new data, but this is something George Condis did when working at George's. But 3,000 consecutive women walking into our early pregnancy service, some with pain, some with bleeding, but only 6% actually had an ovarian cyst out of all those women, which is not so many, only 182. And actually, when you looked at what they turned out to be, in terms of the presumed diagnosis, this is on ultrasound, this is what we thought they were, and out of all of them, only 1 turned out to be a borderline tumour at the end of the day. Remember, that's 3,000 women walking in the door, over about 180 masses, and a very low likelihood that you're actually going to have what you might call a significant mass to be worried about in terms of the histology. And I could just stop now, really, because that's just about the only point I want to make before we move on to the sort of cyst that Antonia is going to talk about, where they're actually, it's difficult, and if the stakes seem much higher because the patient is pregnant and the choice is whether you intervene or not. But as you might expect, when we felt they were physiological, most resolved. Some persisted for about 6 weeks, as you might expect with these types of cysts. And actually, we only intervened, never mind the fact that one of them was borderline. We only had to do anything in a very small number of masses for acute pain. So only 7 out of the total number required intervention, and 4 of them acutely. And this is a table from the paper, and you can see this is where we've actually had to intervene, 7 cases. Some of them early in pregnancy, some of them actually we just removed late in pregnancy, and these were quite large, so people don't have to remove things just because they're a certain size. One of them was aspirated, but as you can see, not many, just 1 borderline tumour, and a few patients came in because they had pain, but their pain resolved. Looking at what we thought it was, maybe their ovaries dropped off, I'm not sure, I can't remember now. So this is the kind of stuff you see very typically, and they'll just resolve or the pain will go away, and these are not a problem. It becomes a little bit more concerning when you have papillary projections and so on, which Antonia will talk about. And it's not just in London where intervention is rare. This is a paper from Zanetta and 6,600 women, and they just found 82 cysts, and this boiled down to 3 stage 1 borderline tumours, so 3.6%. And you can see them over here. The pathology, or the final pathology of masses that removed, only 3 borderlines. So it is not common to see this type of pathology in women when they're pregnant. This is Joseph Yazbek's paper, working with Davor Jurkovic, and this is patients at the 11 to 14 nuchal scan, and essentially they found about 300 cysts over 5 centimeters that were simple, or what they said was complex. But if you look what happened, only 0.6% of these people actually needed to have intervention in pregnancy. Most of them resolved, and this is for cysts over 5 centimeters. They didn't worry about the rest of them. And when you look at the pathology, none of them were borderline tumors. And their conclusion was, there's no point examining the ovaries of women in pregnancy if they come for a scan. And that's Davor's argument. That was his argument, and we sort of discussed this. But, looking at his data, it's not unreasonable. So again, emphasizing the point that most of these people aren't going to come in and have something dreadful. It gets a bit more tricky, though, when you start having things like this, and this is one of the cases we showed yesterday. So you have a cyst like this. What do you do with it? It's not as florid as I suspect the sort of cases you'll show, but do you do nothing when you pick that up at 7 weeks and just leave it for another, few months, which is always slightly concerning, or do you remove it? We just left this, and it was a cyst adenofibroma. If you have a cyst like this that turns up in pregnancy, I think most of you will realize this is a decidualized endometrioma, but if you've got no record of it being an endometrioma in the past, obviously it can look quite alarming, because this will actually look more florid as time goes on. The papillations will get bigger, be quite vascular, and it's quite brave, or you feel quite brave to say that's decidualization. I think in our unit, we've started probably getting a little bit too casual about it. We almost say, oh, it's bound to be decidualization. And we I'm sure we're going to get into trouble soon by sort of assuming perhaps that something's decidualized when actually it's something else. And I think probably it's just the prevalence of the disease is such that we get away with it rather than our skill at picking out one thing or the other. It'd be interesting to see what Antonia thinks. And this is from Ahmed Sayazna, when we just did this little case report. But it's interesting in the literature, for people with decidualized masses, endometriomas, most of them reported have actually ended up with surgery at that time. But I think since 2012-13, increasingly people are tending to not intervene. And I suspect we are going to turn up with people reporting cases they've picked as decidualized tumors that actually have been cancers, and people are going to start getting caught out. And I think that's where I think one of the difficulties lies in pregnancy. And you can see this case, I always think it's interesting, which we described, where he had an endometrioma documented prior to pregnancy, and you can see at 8 weeks it's beginning to look a little bit different, and then at 14 weeks it starts to look slightly concerning, and then it just carries on doing this. So if you see this for the first time with no previous history, obviously, you might think, oh dear, I don't like the look of that. But obviously, we knew what it had looked like before, so it wasn't a problem. But I think people are getting more information about this now. And so it goes on, and that's post-delivery. So I'm going to stop there. I'm going to get Antonia to come and speak. So my point really is, Antonia will talk about management of masses which are relatively complex, but just remember that most masses in pregnancy actually are not worrying. Most of them can be left in situ, even if they're relatively large, and will not cause either acute problems or turn out to be anything that's malignant or borderline. So I'll just get rid of those, leave you with that rather nice magical realist picture from the Whitney Gallery in America, and hand on to you. There we are.
May I use this one? Thank you. Okay, as you have understood, the critical point is ovarian masses with the papillary projections. I have to admit that until this case, I wasn't aware about the presence, about the decidualization. And, but we know that it happens in almost all pregnancies, so we have to take into account. So I suggested surgery for this patient, and it turned out to be decidualization. When I went back looking at the images, I focused my attention on the shape of these papillary projections. Then I met another case, then another one. So I invited my colleagues to put together our experiences, and we collected 18 cases of decidualized endometriomas. All of them underwent surgery, so we could compare with the final histology. And can we reduce a little bit the light, please? So we can compare all these images, and I don't know, I think that you agree with me, the shape, the presence of these rounded papillary projections, usually well vascularized, can be a typical aspect of decidualized endometriomas. So, but the critical point is it possible to distinguish this unilocular cyst from this one? Again, diagnosed during pregnancy, which was a borderline ovarian tumor. So it's really critical, and we want to share, to spread the knowledge, because looking at the series of decidualized endometrioma, you can see that the examiner was uncertain in several cases, and in around 40% of cases, they suggested to be a borderline ovarian tumors. So the title said the management of these cysts. What can we say? We can be sure whenever we have the knowledge of a ultrasound scan before pregnancy, as your case, Tom. If you know the patient and you know there is an endometrioma, perhaps during pregnancy you will find transformation. So no fear, we can continue. Sometimes it can be, you have to be brave, because if you find this lesion directed during pregnancy at 24 weeks gestation, you feel a little bit confident. Look at this one. We decided to wait, and at 31 week, there was a resolution, normal ovary. But I wanted to show you two new cases. I was really uncertain in these patients. Why? Because if you pay attention at the pouch of Douglas, I saw this tissue, and I was really uncertain. I put on color, and it was vascularized. I've never had experience on decidualization of deep endometriosis of nodules in the Douglas. But at the end, we decided not to operate on the patients. And after 3 months after delivery, the endometrioma was, as you can see, and the Douglas was completely free. So reduction also of the nodule in the Douglas. But very recently, another case, Francesca Bonomo is here with us, and she referred this patient to my institution. Let's look together the clinical data. 40 years old patient, 20 weeks gestation, no history of dysmenorrhea, and she started complaining pain in the left inferior abdominal quadrant since the 10th or 15 weeks gestation. So I saw next to iliac vessel this lesion. I hope to show you the video. Can you see the video? So I tried to separate the lesion from the uterus. It was solid, connected to the iliac vessel. I really didn't know, because I recognize a sort of a sausage-like, so I said tubal, but it's so fixed, it seems to be retroperitoneum. I couldn't find a diagnosis. And this was the video of color, so we discussed together. The patient underwent surgery, and the first section and the final histology was decidualized endometriosis. So just to tell you that we have decidualization in endometrioma, but also for deep endometriosis. So we have to do quickly. Ovarian cancer in pregnancy, a rare condition, very rare condition, but we have to be prepared. And on one side, there are cases that you have no doubts. Here you have no doubts. Two bilateral solid ovarian mass, this is the vascularization, okay, and it turned out to be a lymphoma. This one, again, no doubts, it was a Krukenberg tumor. This one, there are metastases from small cell lung carcinoma, but you have no doubts in these cases. So the critical point remains papillary projections. So again, in a multicenter study, we collected only cases with the papillary projections, and the distribution is this one, 56% benign, and 16 cases out of 19 were decidualization, 12 borderline, and 3 invasive ovarian tumors. The preoperative diagnosis was correct only in 50% of cases because we didn't know decidualization and we are uncertain about this. I can show you only one printed image of the single case of endometrioma adenocarcinoma, which are our conclusion from this study. It was a retrospective study, unfortunately. So we can say that the surface and the cyst content can help in making the diagnosis. It means that whenever we have smooth populations and ground class cyst content, we can guess a decidualized endometriomas. Whenever we have irregular population and no ground glass cyst content, perhaps can be borderline. And vascularity doesn't help you. Quickly, what about what I managed the last four cases in the last year? This one, 36, look at this type of papillary projection, vascularization sign, it was a serous. And I suggested, I don't remember why exactly, I suggested surgery. But look at this one. So, pregnancy, and we have a bilateral lesion. So on the right, this multilocular solid, okay? And on the left, a unilocular solid cyst. So on the right, this one, 14 centimeters, and on with the vascularization inside, and on the left, 6 centimeter unilocular solid. What do you suggest for the management? How many decidualization? How many? Nobody. Nobody. So, only one. How many borderline? Okay. How many invasive? Nobody. Would you wait until delivery? How many? Conservative until delivery? How many? How many surgery? In this case, I have no specific rule, but because of the large dimension of this lesion, I suggested surgery. And the result was, on the right, the big lesion, it was high-grade serous carcinoma. So strange, but it was, because it's so rare to have a serous carcinoma in a borderline. The contralateral was micropapillary serous borderline. This one, 42 years old, incidental finding. I saw this lesion. I don't know if you can recognize the cyst. So, ground glass, something like that. And look at this solid component with the vascularization. She underwent laparoscopy, and on frozen section, it was a mucinous borderline tumor, but the final histology was endometrioid adenocarcinoma, well differentiated. She underwent chemotherapy during pregnancy, and she underwent cesarean section with debulking surgery at 34 weeks gestation. Tom, 2 final cases or no time?
You can literally show the pictures and then move on, because we are terribly short of time. Quickly.
Quickly. Sorry. Sorry. So I was very impressed by this case, 34. So elevated CA1 to 5, and look at the video. It doesn't fit with anything. It's not solid like Krukenberg and the others. No decidualization, no nothing, but very bad appearance. So the vascularization is this one. She underwent laparoscopy, and it was high-grade serous carcinoma, stage 3A. So again, chemotherapy during pregnancy, induction preterm labor, and optimal cytoreduction after birth. So after all these negative experience, I met this patient, so normal ovary on that side, and this lesion. How many decidualization? Quickly, but how many borderline? 50%. 50%. So the color doesn't change your mind, I suppose, or does it? Doesn't change your mind. I decided for decidualized endometrioma. So I am waiting for the labor, and I will check after birth. So too difficult. What about this one? Decidualized. What about this one? Borderline. Just to leave you with this strict message, we have to go out. Whenever we have an endometrioma before pregnancy, it's easy. Let's wait, perhaps we will see some papillary projections. But please keep in mind irregular surface, some anechoic areas, and no ground glass. It can be borderline ovarian tumors. Thank you so much.
Thank you, Antonia. That was great. I'm so sorry to rush you, but I think we're pretty behind. Right, I'm really pleased to introduce Frédéric Amant, who has, well, until relatively recently, and still does work at KU Leuven, but is now also leading the gynae-oncology team in Amsterdam. Frédéric really runs the international registry on cancer and pregnancy, and I guess when you think about it, well, certainly when I was many years ago, I think if people got cancer and it was early pregnancy, people would start saying, well, you need to terminate the pregnancy, and I still think in some places women are told that, but Frédéric's going to discuss how you manage cancer in pregnancy, and I noticed in Antonia's case, the woman with ovarian cancer got chemotherapy and then treated afterwards, so I look forward to Frédéric's lecture, but about 1 in 1,000 to 1 in 2,000, I think, women get a diagnosis of cancer in pregnancy. So if you look at that in the whole of Europe, it means there are a lot of women who potentially may have been suboptimally managed. So, Frédéric, over to you.
Thank you, Tom, for this kind introduction. I'd like to thank also the scientific committee, Dirk, Tom, for giving me the chance to share with you some recent and an update on the management of borderline and invasive ovarian tumors in pregnancy. My take-home message is the following. Regarding the diagnosis, and this is mainly why you are here, is sonography is much better than serum tumor markers. I want to show you that chemotherapy during pregnancy is in fact safe and adds to a better treatment of cancer during treatment. And last but not least, that this is a complex situation that an interdisciplinary approach is mandatory. This is the agenda. Some diagnostic issues have been told. I will skip these slides. We will focus on surgery, chemotherapy, the maternal side, the fetal issues, to focus a bit on ovarian cancer and its treatment as such, and then to underscore the importance of the interdisciplinary approach. I will not share this with you, as Tom and Antonia have been said this. This is an overview of how we should treat, or how we think we should deal with these masses in pregnancy. If it's symptomatic, treatment is mandatory. In asymptomatic masses with benign features, a wait-and-see policy. If it's highly suspicious, we can do an MRI. I'm not sure if Vincent is still here, but he will agree on this. If the mass is indeterminate in the first trimester, you may go for a follow-up after the first trimester. In second or third trimester, in this case, an MRI may be the next step. So this is a show of a flow chart on how we think we should deal with these masses. In the International Network on Cancer, Infertility and Pregnancy, in January this year, we now have nearly 1,600 cases, and out of these, breast cancer is the most common cancer, cervical cancer 11%, 10% lymphoma, so 9% are ovarian cancer. So I agree with Antonia, it's not, you won't see too much, but nevertheless, in this heredity, in fact, 9%, nearly 10% of cancers in pregnancy are of the ovarian origin. If we further see what kind of cancer this is borderline in 43%, epithelial cancer in 34%, and 12% germline ovarian cancers. Robert Fusio, who is somewhere here in the audience, he's part of this international network, and he's at this stage further analyzing in depth these ovarian cancer cases. Tumor markers can increase during pregnancy. There are not so many data, and here I summarize two publications. And actually, the basic message is that CA125 can increase, and this is mainly in the first trimester, and scores up to 5.5 units per milliliter have been reported. Due to the pregnancy, ACG and alpha-fetoprotein for the germline tumors are not, you cannot use for the diagnostic issues during pregnancy. Granulosa cell tumors, inhibin and AMH we can use, but however, this is not the age population where you can, where you expect basically these granulosa cell tumors. So these serum tumor markers are suboptimal for the diagnosis. I will not further focus on sonographic findings. I think Antonia and Tom have detailed this with very beautiful images. What may be an added value is, and this is the collaboration we have with Vincent Vandecaveye, is the use of whole-body diffusion-weighted MRI in ovarian carcinoma. And here we see a patient with ovarian cancer, advanced stage ovarian cancer during pregnancy, where you can see also the peritoneal lining by cancer also during pregnancy. And we believe not only for the diagnosis, but also for the staging of these cancers that this MRI may be of use. We had a prospective single-center study where this MRI was more accurate than the conventional imaging during pregnancy, and we believe that this is, can be of further aid in this population. This is an example of a patient with stage 4 cervical cancer, filled with a malignancy. Also on CT, we could see pelvic lymph nodes, but what we did not see on CT is a bone metastasis in the scapula. So just to show the impact of this MRI also on the management of this patient. Regarding cancer treatment during pregnancy. We will now focus on surgery. Basically, if you treat the mother well, you treat the baby well. We have a lot of experience of surgery during pregnancy, mainly because many benign conditions are operated during pregnancy, for example, an appendicitis. So we put the mother at the left lateral tilt position, especially after 20 weeks, what we see here. If the fetus is not viable, we propose not to monitor because there will be no clinical consequence. However, in a more advanced pregnancy, we can monitor the fetus. As you can appreciate, the fetus is sleeping together with the mother, and you can also monitor the contractions. There is always the question, what kind of if you do a tocometry, what do you do with the contractions? And do you have to give tocolytics? We have summarized all the recommendations on maternal and fetal surveillance when pregnant women are operated. But when we operate on the ovary, which is today the topic, actually our analyze or recommendation is to use the drugs, especially when ovarian cancer is operated. There's always this manipulation of the uterus. If we operate for breast cancer, we don't give it as a standard treatment. We can also do laparoscopy during pregnancy. The data are limited, but the safety has been shown in procedures which were not longer than 90 minutes, not to use a pressure which is too high. An open laparoscopy, that means that you open the peritoneum under right direct vision, because there have been publications with perforation by the Veress needle of the pregnant uterus, so we need to avoid this. And to avoid this, you also need the experienced surgeon. Because the pregnant uterus will fill the abdomen, the laparoscopy is only possible until 26 or 28 weeks of gestational age. What about chemotherapy? We advise our pregnant women not to drink alcohol, because women who drink alcohol on a regular basis during pregnancy, they will deliver a baby with a high risk of the fetal alcohol syndrome, which is characterized by facial dysmorphia and cognitive impairment. Women who smoke, their babies are at risk for intrauterine death, antenatal delivery, or small for gestational age babies, and that's why we recommend them not to smoke. But chemotherapy is designed to kill cells, and nevertheless we give chemotherapy during pregnancy. This lady is Leslie. She suffered from breast cancer, and she's treated with FEC, so 3 types of chemotherapy during the second gestational trimester. So we do this because we believe that if you give chemotherapy after the first trimester, chemotherapy is not associated with more or different congenital malformations. This is one of the seminal papers from our group by Professor van Kalsteren, and actually the congenital malformations are in red, or the major congenital malformations are in red, and here at the left you see the different treatment regimens, and you see that actually the most important major malformations are mainly actually in the groups where chemotherapy was not given. Here we have one hip subluxation, which you can consider or you can doubt, which is if this is really a malformation. And here we have rectal atresia, which is also one of the more common congenital malformations. And from this and other publications afterwards, it appears that chemotherapy after the first trimester does not induce more or other congenital malformations. So we can reassure our patients here. But if we give chemotherapy, there appears to be a tendency towards intrauterine growth restriction, towards premature labor and premature rupture of membranes. The data now are not solid enough to really pinpoint what is really inducing this, but there appears to be some trend. So for obstetricians, this is an important message. We should really look into these clinical parameters. But for many people, if you are doing this sonography, you will see these patients as well. And what is very important is that before any treatment is given, we need to confirm the pregnancy, determine the gestational age, and we need to exclude pre-existing fetal anomalies by ultrasonography before any examination or intervention is done. Because otherwise, afterwards, if there is any problem, you will not be able to link this to the treatment or not. And during the cancer treatment, as I've shown you, there is especially in patients receiving chemotherapy, fetuses are at risk for intrauterine growth restrictions. For sonographers, it's important to check for intrauterine growth restriction. Probably some obstetricians are here also. I think the mode of delivery is determined by obstetrical indications. The only reason to really do a cesarean section is cervical cancer, which is still in situ. Otherwise, it's mainly an obstetrical indication. And the timing of delivery, we try to focus to deliver mature children. And I will share with you, I will show you why we prefer this. The first study on the long-term outcome of children was in 2012, and this is the most important slide. We see here the IQ score and the pregnancy duration, and you see as the pregnancy continues to evolve, the IQ score is better. What we don't know here is what is the effect here. So these children are doing worse. Is this effect now related to the chemotherapy, or is this effect related to the prematurity? So this is what you cannot discern. So these are actually suboptimal data. So we improved these data. We added a control group. We focused on children who are 3 years old. That was the main difference. We did this in 4 centers in Belgium, the Netherlands, Czech Republic, and Italy. So basically we had 100 children who were exposed to chemo and/or radiotherapy. But we should not forget that apart from this, some of them were operated, they had all imaging, they had supportive drugs, they had a stress, and this in fact can also add to the fetal outcome. What did we do? We had collaboration with our pediatrics department. Children had a general pediatric and clinical neurological examination. We looked into general health. Tineke van den Broeke is one of our psychologists who in this study did the Bailey scale of infant development, and Magali Verheke, another PhD student from the obstetrics department, does the echocardiography in these children. Median age 22. Actually, basically, there is no big difference between the prenatal and the study group and the control group. What is important is that 61% of the children were born preterm, and we will see what this means afterwards. Looking into the postnatal growth, left males, females, we look here to the length, to the weight, and to the head circumference. Triangles are control groups, and ovals are the study group. Basically, there is no big difference between both study groups. Some of the children are born have a lower birth weight, but we see that during the 3-4 first months, they catch up this biometry. They were actually looking into the incidence of medical problems, need for surgery or medical care. There were no differences between the study and the control group. This is in fact one of the 2 most important slides of this study. If you look into the study group and the control group, these curves virtually overlap. So these treatment modalities do not affect the cognitive outcome. If you do a sub-analysis for different types of chemotherapy or different types of treatment, in black are the study groups, in gray are the control groups. You can see also from the last, at the back in the auditorium, that there's actually no difference here. So also for these subgroups, there is no difference. If you look into the numbers of chemotherapy, we have 1 or 2 cycles, here 6 or 7. This is the cognitive outcome. In fact, there is no difference. So if you give 1 or 2 cycles or 6 or 7 cycles, in our study, this did not impact the outcome. And that is, I think, the second most important slide, because here we have the first slide from Lancet Oncology, but now with a control group. And you see the same tendency, but this is the same tendency for both groups. So the fact that these children who are born preterm do worse really is due to their early young age and not due to chemotherapy. So the message here is it's better to give chemotherapy and to prolong the pregnancy, and this will result in a better neonatal outcome. So Magali looked into detail into the heart data. We will not go into detail, but you can appreciate that we looked into a lot of different parameters in patients and controls. In fact, there were no clinically significant differences, and this is in patients who received anthracyclines, which are notorious for their cardiotoxic effects. In the first publication, there were also children who were older. A child which is older, you can do more detailed tests. So we looked here into the behavior, to the memory and attention. You can see that the numbers are smaller. There's no control group. Results were expressed as a Z-score. Everything which is between -1 and +1 is normal, and you can see that, in fact, in all these parameters, there is actually well below the normal levels. So even on the long term, this appears to be safe. At this stage, we work into a group with controls for these older children, and at this stage for children who are 6 years old. If we summarize these data, we can say that if you put 10 children on a row and 2 of them received chemotherapy during pregnancy, well, I will not see the difference. I will not be able to identify this child, you neither, but more importantly, the researchers from our group who really look into detail into all these parameters, also they cannot discern these children. And this is the main message we want to give to these pregnant mothers and fathers. Why is this? This is because the placenta is an active organ. It contains receptors that really can protect the fetus from chemotherapy. In everything what we tested, there was always less chemotherapy at the maternal side when compared to the fetal side. Regarding ovarian cancer, we had this is the second international cancer consensus meeting we had here in Leuven, and I will summarize in 4 slides the most important data. Borderline tumors are most likely to be stage 1. We can operate, we can do a staging as in non-pregnant patients. In higher stages, we would say you cannot debulk during pregnancy until no residual tumor. So in borderlines, we would postpone this until after pregnancy. For invasive cancer, if it's early stage, we can operate, we can do pelvic and parotid lymphadenectomy, we can give the chemotherapy, so that is perfectly possible also during pregnancy. But in advanced stage, well, we have to say that this is still quite experimental, but the main message is you cannot debulk also here during pregnancy. So take a biopsy, make sure that you're sure of your diagnosis, you can give the chemotherapy and postpone the surgery until after delivery. Non-epithelial tumors are usually stage 1. Again, surgery is possible. We would, for stage 1, grade 1 immature teratoma or stage 1 dysherminoma, even give no further treatment. Otherwise, we would give paclitaxel and carboplatin. This is an example from the clinic. You're better sonographers than I, so you will agree that this is a suspicious mass. We also did an MRI. It appeared to be, so we operated at 14 weeks, unilateral salpingo-oophorectomy, omentectomy, peritoneal biopsy, stage 1, grade 1 dysherminoma, and no further treatment was given. I will skip this one for the purpose of time. The interdisciplinary approach is important. I think oncologists have to discuss with perinatologists, with sonographists, with obstetricians. For example, here we use the corporeal uterine incision for a patient with cervical cancer because there are some reports of an abdominal wall metastasis after low segmental uterine incision. So the message is try to stay as far as possible from the cancer. Also, this cesarean section, for pelvic cancers at least, this is a moment of surgical staging. So this patient had cervical cancer, the same patient, she had positive pelvic lymph nodes, and we used this moment of cesarean section to parotically stage the patient that would allow us to tailor the adjuvant radiotherapy after the delivery. Recent data, retrospective, but focusing on the psychological distress and coping of the patients. I will go fast. The first aim was that we looked into the parents, and basically the main message here is that also we look into the fathers, because the needs of the fathers are as high as the needs of the mothers. Basically, if into the coping mechanism, we could identify positive coping strategies, internalizing coping strategies, and some women have a blame strategy. The clinical recommendations here that we should give rational and balanced information to our patients about the disease treatment, the prognosis, the evidence of the outcome, follow-up, and how we should follow up these children. We need a psychologist to evaluate this, especially if there is a problematic coping strategy. These patients basically need more help. We do not forget the father. We look into emotional relationship difficulties and to stimulate attachment to the newborn, social worker, and to look for peer support. This is what our patients need. So I hope I could convince you that we should rather use sonography than tumor markers, that chemotherapy is possible during pregnancy, also for ovarian cancer, and that this interdisciplinary approach is mandatory. Who is interested in this field, you're always welcome to become an INSIP member. I need to thank the authorities that pay our researchers. Just 2 slides to show how we want to thank also our patients. This is on a 3-yearly basis. We have this family day. We want to thank, to be grateful for the parents, for the children, to always come to Leuven to have these investigations, because this is a risk we have. If you want to follow up these children for 18 years, you will have these dropouts. So this is one of our strategies to prevent dropouts. And then those who are interested also in, well, within 2 weeks, we will have this INSIP meeting in Prague, where we will have a traditional meeting, but we will also have a meeting where we really discuss the research. You're more than welcome if you're interested. Thank you.
Vincent, it was fantastic. I mean, that you've taken this piece of work and driven it, and the follow-up for these people. I mean, it's such a huge amount of work that you've done, so congratulations. Any questions from the audience? We had a discussion earlier about borderline disease and whether, well, if you take the view that you can be fairly certain that a mass is borderline, say in the first trimester, is it acceptable to leave it in situ and not remove it? And do you, what's your view on that? Because we were talking about this earlier.
I think it depends also a bit on the magnitude, the risk of torsion. I think you always have, if you plan it, if you do well-planned surgery, versus surgery in the emergency where the patient is full of pain, I think we have to discuss with your patient. If you opt for a conservative approach, this is a bit more risk for a rupture or a torsion, which may induce or necessitate urgent emergency surgery. So this is one of the things at least we discuss. I think also the magnitude of the volume of the cyst is also important. If it's really too large, I think the patient may suffer from pain later on during pregnancy, and then it's maybe less ideal when compared to the first or the third or the second trimester. So I think this is something we always try to discuss with the patient and to delineate the different possibilities of what could happen if you do not operate.
Any other questions or comments? I think that you've reached a point where they all need coffee. But Frédéric, once again, thanks so much for your work. Thanks again.
Good evening and welcome to the exhibition area. Today we are with on the GE booth with Dirk Timmerman. And Dirk, nice to see you this evening. Nice congress. Can you tell us about the congress, and can you summarize a little bit the congress of today?
Pleasure. Well, he is a happy man. Today was a great success in my view. So the day started with an overview of where we are with IOTA. Then there was an extremely interesting lecture of the development of cancer and how to control cancer, so by Professor Karmelit. Then there was the first results of IOTA 5, which are very important because these are cysts that are managed conservatively, and see how safe this is. So this is really fantastic new results. And then this afternoon was great as well. We had liquid biopsies, and we had the guideline session, and then the session on borderline tumors. So I really loved it.
I have another question. Do you have already the date? Do you have already the date of the next session for next year, in 2 years?
This is not organized, so the next session will be in 2 years' time, like you say, so it will be 2019.
Okay, but we don't have the date already.
That's still a secret, but...
Okay, so thank you, Dirk. Nice to see you, and see you soon on the web. Thank you very much. Goodbye.
Thank you very much.